Please find a seat here and we'll get started again. A lot of good questions during break, which I don't mind questions now that I wear Depends. It's a piece of cake, so. Yeah, that's true, and just to, as we get into this now, I'm going to talk, let me put it this way. I would be remiss to talk about codes without talking about documentation. This is not a documentation class, but it is. And so I will start off teaching about documentation first of what is required nowadays. And I'm not talking about Medicare, I'm talking about everybody, including even your cash patients, okay? However, while I am teaching, if you have a question, feel free to raise your hand, and I'll repeat the question for everybody here, but I will probably handle most of your questions in the lecture, but if there's something that's just burning a hole in your mind, then by all means, please feel free to ask, okay? All right. Well, thank you again for coming back here. Let's talk about the consultation. And if I talk to you about Medicare, I'll let you know. But in general, my talk about documentation is in general and actually is not Medicare. But when you look at it, Medicare and the things that they say has now been adopted by most insurances, all right? And so therefore, if you were to do your documentation, I'm not talking about coding, but documentation to satisfy Medicare, you'll probably satisfy everybody else. They'll probably say, pretty good job. And I'm not talking about subluxation, I'm talking about documentation itself, okay? And when you talk about documentation, the very crux of everything is the chief complaint. The chief complaint, according to guidelines, and again, this is not Medicare, this is in general, the chief complaint has to be clear, concise, and legible. One doctor's office, and I don't work for insurance companies per se, I don't do peer review for sure, but when a doctor asks me to come in and says, I'm having problems, I just got an email yesterday, I'm having problems, will you please help me with my documentation, let me know what I'm doing wrong. And so that's why I talk about going into doctors' offices to help them out. And one doctor, I looked at her notes, and it said patient, the S part of the note, it said patient able to golf. That's all it said. And I said, do you run a golf school? And she was sitting right there next to me, and she looked at it, and her mouth literally opened. She said, oh my God. Because I'm like you. I see about 50-some patients a day. I'm clicking away here, and we're taking care of patients, trying to do the right thing for documentation and everything else here. That's why I have somebody assist me, in the room. But the key is sometimes, you got to have a way to go back and look at your notes, kind of self-audit first. And just see, is this right? Am I doing the right thing? Okay? All right. So number one, chief complaint. Now, in the 99203, which is a new patient, kind of like intermediate type of E&M code here, you have to show the past health history, family history, and social history. So this is the interactive portion of the class, okay? So somebody raise your hand, let me know, why do we care about family history? Like, ooh, you have 9 children? Cha-ching, right? No. Okay, why do we care? See, I was wondering, you were wondering where I was going with this, right? Okay, so why do we care about family history? Yes, sir? Right. You had me at genetics, okay? So you don't have to say any more, okay? It's heredity factors. Okay, it's heredity factors. Okay, you get the karaoke with Mario CD. Okay, it's in the mail. All right, so we're looking at family history. Now, first of all, just so everyone knows, who is family? It's like the more money you have, the bigger the family you have, right? Hi, I'm the third cousin of the fourth uncle of, it's like, get out of here, right? So family, we are family. Okay, yes, we have that now on video. Okay, so number one, mother, father, brother, sister, grandparents, both sides. That is considered family with EHR, meaningful use attestation. Mother, father, brother, sister, grandparents, both sides. Now, we're looking for, as the good doctor said here, genetic hereditary factors. So in your notes, next to family history, just write down hereditary factors. So orthopedic, which is arthritis, we're looking at rheumatoid arthritis. Do you have any family history of rheumatoid arthritis? Yes or no? If yes, please explain. Now, I don't know about you, but in Decatur, Illinois, where I'm from, patients don't always fill out forms very good. Okay, I'm sure here it's not a problem, right? Okay, and they write N/A, which in our area stands for no answer. Okay, all right, and not applicable because I wouldn't ask it if it wasn't applicable. So, as an example, I'll say to a patient, okay, you left this blank here, or you wrote NA. This is what I'm looking for: mother, father, brother, sister, grandparents. Do you have any rheumatoid arthritis in your family? Yes or no? Okay, and then you write down mother, rheumatoid arthritis. Okay, how about MS, multiple sclerosis? How about heart disease, cancer, diabetes? With cancer, be specific. What kind of cancer do they have? Breast cancer, transferred among the females. Prostate cancer, heart disease. I had a patient come in, 32 years old. Grandfather died when he was age 50 from heart disease. Father died age 55, and he's 32. I said, have you had your heart checked? He said, I already have 2 stents. That's not me, okay? So the key is that here it's going to give you some of the things, the red flags to look for, okay? So the big 5 is arthritis, MS, cancer, diabetes, heart disease, okay? All right. Past health history. Okay, someone else help me now. Why do we care about past health history? What does that tell us? Past health history. You get no lunch till you answer the question. Past health history. Yes, ma'am. If they, okay, you trailed off probably at the most important part. They had chemo or something, what? How will it, why do we care that it affects their body? So, why do we care? Okay, so why do we care? Somebody else help her out. Why do we care about their past health history is the question. Somebody, please, help us out. Come on. You're all giving an answer, but your arm obviously is in a sling. Raise your hand. Who's answering? Okay, yes. No, that's not it. Sorry. Okay, what else? Past health history. Anybody? Go ahead. Predisposing factor, okay, to what? It's actually called a comorbidity or complicating factor. Okay, if a patient comes in and said that I'm having chemotherapy, and that's where I thought she was going with it there, their body is in a weakened immune system, and so therefore they're not going to heal as quickly. Okay, now, when I say this here, that is one of the things with insurance companies, one of the 2 major issues that chiropractors do not address. It gets you more visits. If a patient comes in and said, I've been to the neurosurgeon, they said I'm not bad enough to do surgery, but they sent me to the pain center and I didn't respond. They said I have canal stenosis. Now, is that patient going to heal in 2 visits? No, right? And so, therefore, past health history, number 1, it's like, when did you first start having headaches? And so, that is going to give you some of those complicating or comorbidity factors. Social history is the lifestyle factors. You're married, it'll take twice as long to heal, right? No, okay? No, I'm just kidding. All right? So social history is their lifestyle factors. Employment history, are you employed now? Are you retired? Are you working part-time? Occupation, what did you used to do? And as doctors, as I'm sure you know, you want to ask them not what did you do, because that's their title, but ask them what did you do? In other words, mechanical engineer. I have mechanical engineers who wear a hard hat and are in the plant all day walking around. Okay? I have other mechanical engineers that wear a nice dress shirt. No one wears ties except me now, right? And they are sitting at a computer all day. So asking them what they do is going to help you figure out their lifestyle. All right? Now, National Committee for Quality Assurance. You may not know that, but I will tell you that every contract, including whatever documentation that H&S has, requirements, it all goes down to the NCQA guidelines. NCQA guidelines state that any patient over the age of 13 that you see 3 or more times, you have to check for their drug use, alcohol, and tobacco use. Now, drug use is over-the-counter, prescription, and illegal. Alcohol is gin, rum, no. Alcohol is alcohol, but tobacco is, do you currently smoke? When did you quit? Former smoker? I had a patient come in, and I said, do you smoke? He said, that's funny, my medical doctor just asked me that yesterday. I said, what did you say to the doctor? I swear to God, this is what he said. He said, I told him I quit. I go, well, when did you quit? He said, just before the appointment. Seriously. And I said, when did you start up again? He said, just after the appointment. You know, they're tricky. And that's a true story. And I said, okay, so you smoke. How much do you smoke a day? You know, things like that, okay? So drug use, alcohol use, tobacco use, all right? Sexual history, wouldn't you like to know if they are hepatitis C positive or have HIV or AIDS? Okay? Now, you still can treat them, of course, but you might want to take precautions if they are active hepatitis C. I just had one last week. She said it's in remission, hepatitis C. Okay? All right, so of course we have OPQRST. All right? The O, the onset, I've already talked about that, box 14. Here is when did they first have the symptoms. Well, if they said, well, I've been going, it's Old Faithful, it's been going on for years and years, I'll say, okay, when did yours flare up? About 2 weeks ago. Then you document that. The intensity is going to be important as well, because if 0 is no pain, 10 you're in agony, what is your pain? Some doctors even use the FACES pain scale, which actually is for learning disabled people. Okay, it doesn't matter. Very few of us actually use a true VAS. A VAS is a line 100 millimeters long, patient marks it, you measure it, and that is objective. But if 0 is no pain, 10 you're in agony, that's actually the verbal numeric rating system, okay, which actually is one of the approved tools that you can use to get their pain intensity for Medicare PQRS. Okay? All right. Quality of pain, is it dull? Is it sharp? Okay? Those of you that see Medicare patients, you have to do PQRS. And PQRS, Physician Quality Reporting System, states that each visit you have to ask them the pain level and also the quality of pain, which is it dull, sharp, or stiff, whatever it might be. Okay? All right, the SOAP note. Some, they'll use SOAAP, and that's for activities of daily living. I don't care what you use there, as long as you do it. But I always think of Marvin Gaye. And my wife, she said, those young people, they don't know who Marvin Gaye is, all right? Look it up. It's a great song, okay? Talk to me, sister, so you can see what's going on, right? Okay? All right? And so let's face it here. Everyone, staff as well as doctors, we know our patients, don't we? Right? We know our patients. We know the problems they're going through, the stresses they're going through. We know when they're going on vacation. All right? And so here it's reporting of the patient's pain, their limitations, concerns, and problems. One of my patients, until recently, she was always throwing her back out because her husband, she was having to lift him up. He had brain cancer. Okay, he's Jack now passed away, okay? But the key is that's why she was having exacerbations. Explain it to us here, okay? It could be a quote. It doesn't have to be. One said, doctor, I was on 8 Vicodin a day. Now I'm off of them completely. All right, so put us in the encounter. Let us know how that patient's really doing. The objective part, that's where you're the scientist. Now, what did you find? Okay, so now you're going to use your senses, vision, hearing, smell, touch. We don't taste our patients. Okay, yeah, that's an SI problem if ever I tasted one. Okay, no. Okay, we don't do that. See, you never thought you'd be laughing at an ICD documentation class, right? Okay, so here it's now, vision. What did you see? Antalgia, scoliosis. Okay, hearing, crepitus. Smell, I don't know, but touch, that's our life, right? I'll touch a patient, I'll say, does it hurt here? And they'll say, how did you know that's where it hurt? And I said, I feel your pain. And I really do. You're welcome to use that. But you know what? Subliminally, the patient knows, Dr. Mario knows where my pain is. I've been in practice now in June, it'll be 29 years. For me, and it's almost like I get emotional, when a patient comes to me and says, my brother-in-law said I should come in and talk to you because if you could help me, you would let me know, and if you couldn't, you would let me know. Isn't that what it's all about? Okay? Do you know what doctor means? One who knows. And so, use your senses. You talk to the patient. Because not every patient can we help. A patient comes in, I've got really bad headaches, I've had 3 strokes. Okay, you probably don't want to be adjusting their cervical spine. Okay? But by all means, it's like, okay, lay down, let me feel. And say, you know what, you don't need to see me. That's what we use here, okay? All right. Now, in Medicare, and I'll talk about Medicare briefly here, part with Medicare proves a subluxation occurs, that it's there. Part proves a subluxation exists, okay? Often when I'm seeing a patient, this hologram appears in front of me, and believe it or not, it's not Parker Binder. Okay? It's a Medicare reviewer, and the Medicare reviewer looks at me, and I said, hello, Darkness, my old friend, it's good to see you again. And they said, Mario, is there a subluxation there? And I said, yes, there is. And they said, where? L5. Prove it. The way you prove it is with part. It is not your SOAP note, but it's the way you prove it. And if you think about it here, PART really is every insurance company. It's required with Medicare. And when the P, which is pain or tenderness, if you look at it here, it says through observation. What does that mean? Well, I don't know about you, but in my office, some patients will say, it hurts right here, doc, right SI. That's good enough for the P. Okay? Or they'll say, turn around, and they'll say, and they point on my back. They'll go right there. That's where it hurts. Okay? Percussion, palpation, provocation. Does this hurt? No. How about now? Okay? So tenderness to palpation, but always give the segment. Give the segment, not just lumbar. All right? Now, alignment or range of motion, and geeks who study this, they always study this over here. And you know what? It doesn't matter what you call it, because asymmetry is sectional or segmental level. Range of motion is sectional or segmental mobility. It's the same thing. But Medicare says you have to have either alignment problem or range of motion problem. So whatever you call it, aberrant motion, fixation, high hip, decreased joint motion, decreased joint play, even PRS-M all works. The T portion of the part is your spasmometer. Did you guys bring one? Anybody have one? I think I bring mine. I carry it with me all the time. It's what you feel. It's your spasms, your edema, hypertonicity. So out of the 4, PART, 2 of them have to be present, minimum, and 1 of them has to be either the A or the R. So look up here on the board here. A P and an A gets you paid. You could have PA, PR, AR, but Medicare doesn't pay for PT. Ooh. Hey, when you're sitting in the airport and your plane's been delayed again, you got to have something to think about, okay? All right. All right, E&M codes, all right? E&M codes. I just did a crash course last week on E&M coding, all right? I still say, who cares? Because, you know, whether it's problem focused or whatever, do you really sit there and say, this is a problem focused code, okay? All right, the bottom line is when it comes to E&M coding, there's 7 different categories, and 3 of them are the most important, which is your history, exam, and medical decision making. The history, we've been talking about the history. The history portion of the E&M code is the history of present illness. It's their past health history. It's their social history. It's their family history. That's the history. The exam is what you actually do to the patient. Medical decision making is, let's think about it. And that's your professional judgment. In your SOAP note, S-O-A-P, the S is a mini version of the history. The O is a mini version of the exam, and the A is a mini version of the medical decision making. And again, literally, the doctor's office I was in Thursday, it said patient assessment, patient improving as expected, 68 times. Is that why you're sitting in class to tell me the patient is improving as expected? No. Give me your professional judgment. How is that patient doing? All right? So history, exam, medical decision making are the major categories. The more complex it is in your E&M code, then the higher the code. We usually don't do a level 1 exam because that's not even made for doctors. That's a nurse's code. We don't do a level 5 exam because that's life and death. That's ER time. A level 4, probably not that much, but that's where medical decision making is like, that's a tough case. The red flags, like one doctor was saying. Patient may have a ruptured disc. They've got cauda equina, urinating down their leg. How often do we see that? Not often. I've had 2 in 29 years. Okay? We don't charge by time. Time is the least important because we're not plumbers, right? We don't go by the hour. Okay? So HPI, that's basically the OPQRST that I told you about. Review of systems. Now that's the red flags. Did you know that if you don't do a review of systems, and that's the second one, remember, I told you there were 2 things there, past health history, and review of systems is not usually done by the chiropractor. But yet we do it, we just don't write it down. The review of systems is the differential diagnosis. Take that to the bank, if you will. A review of systems is your differential diagnosis. No matter what, okay, am I speaking as like, wow, Mario, where'd you come up? You know, a patient comes in with back problems. Do you have any leg pain, any abdominal pain? Do you feel any numbness, any tingling, any weakness, any bowel and bladder changes? I just went through 7 of the review of systems. If you have 0, it is now a level 1 exam. It means you weren't even in the room. Patient comes in with headaches. Do you have any ringing in the ears? Do you have any visual changes? Any dizziness? Right? That's all your review of systems. Make sure. Now, a review of systems, what is a true review of systems? It's a review of the systems, which means it's not a questionnaire that the patient checks off. Okay, the E&M guidelines state that for every insurance, everybody on earth, including cash, by the way, that when they mark a list, as they do even in my office, that's past health history. When you review it with them and make sure, it's kind of like hit the highlights, the important stuff there, that's a review of systems. And that's why when we talk about review of systems there, we'll talk about all of these systems here, and the best way I like, and that's what the guidelines state too, denies shortness of breath, complains of whatever it might be. That denotes that you discussed it with the patient. If you don't do it now, start literally like now. And that's not because of ICD-10. That's old news there. How old is it? It actually started off in 1995. That's when the guidelines came out. Okay? All right. So again, you're going to check the patient, you're going to do an inspection on that patient, and then vital signs. PQRS, Physician Quality Reporting System. Last year, 2014, it was required that all of your active care Medicare patients that you took their blood pressure at least once. This year, they did away with that requirement. I kind of liked it. You know why? It made doctors be doctors. Literally. I had, God gives me these things so I can teach it to you. I had a patient come in. She was having headaches. I did her blood pressure. It was 256 over 100 something. She's a young lady. She's probably like 30 something. I thought there is something wrong here. And I did a review of systems. She was having dizziness and having some tingling in her lips. I sent her to her family doctor. I called up the family doctor and I said, this is not a chiropractic case, there's something going on. She's got a brain tumor. Okay? Now, I am a hammer just like you. I want to hit every nail, right? I want to adjust it, but there's certain people where we can't adjust. You have to know when not to adjust. This is so serious. We don't cause vertebral artery dissections as much, that's 1 out of every 5.8 million adjustments, as much as they come seeking our care. So again, do those vital signs. Well, Medicare doesn't require it. Nobody requires it. Well, fine, still do it. The patient comes in with a massive headache. Doc, this is unlike any headache I've ever had. That is pathognomonic for a vertebral artery dissection. Get that blood pressure, both arms, by the way. Okay? All right. Palpation. Obviously, we do that. That's not a problem there. And so orthopedic neurologic tests, doing your exam here, make sure that you document it. I mean, look at their body. Look at their shoes. You think this person has back problems? We were at the mall last night because our iPad is acting up. Okay, we never did get it checked because they said it'd be an hour and a half wait, and we're sitting here waiting, and then I started to complain to my wife. I said, I am wasting so much time here. We travel all day long, and now we're sitting in a mall. And she can tell you, we actually said that. So while I'm sitting there, I am watching people as they're walking by. Okay, I don't know about you, but it's kind of interesting. My wife goes, what are you looking at that girl? And I'll say, she's got an SI problem. Look at the way she's walking. Or seriously, or their feet, like this, And now she'll say, look at that one. I bet she's got a knee problem. See, she's a convert, okay? So we are professional observers. So again, observe, okay? Now, moving on to ICD-10, the new coding system will mean new coverage policies. Your documentation, some of the stuff I just gave you, if you're not doing it, this was so basic stuff. It's like, where's Mario coming from on that? Believe me, if you don't do what I just talked about with documentation, you are not compliant, period. And I'm not talking about Medicare, I'm talking about everybody. It's risk management too. Medicare requires part, but isn't that what we do? We palpate. Does it hurt here? Right? All right. So changes will be made to accommodate increased specificity. That was the first section of this class. That was the theme word there. Second one was ordinality, right? Okay. So now, when we look at this here, coding is more specific, and is the transition, the impact is what we're talking about now in this course here. The impact here, it's difficult to measure. Again, will there be a 6-month delay in reimbursement? I don't think so if you do it right. The only reason why, and this is, I'll say from the podium, literally, is the only reason why there is going to be a delay is because you're not doing something right. I really, really don't think it's going to be the insurance company. They have spent hundreds of thousands of dollars getting ready. Blue Cross is ready. Okay? They will be ready. And so when they look at this here, they have their own internal policies. Now, they want to make sure that the patient is getting medically necessary care. They want to make sure that you are documented. It's not just to cut reimbursement, is it? Okay, some say it might be. You know, and after all, because some insurances, they will do anything they can to deny your claims, including this one here. You didn't say, "Mother, may I?" Okay, all right, okay. But the key is, if you are ready, there should be no reason for any delay. So now, number one, okay, H&S is there. They got your back, okay? No pun intended, okay? I know, I've been to their site, and you know, this is some of the stuff that is even on their website, and Parker asked me, she said, look at our readiness plan, see what you say, and I added in a few things there, and that's on their site. It's posted already, isn't it? Okay, she's going to give those out at lunch, okay? But I beat her to it. I gave it out at 11 o'clock, okay? All right? Okay, this is not, we are going to give it. But this here came from CMS. And it's just your vendor, okay? They're here, they got your back, but you know what? You got to talk to your vendor now. So the transition, this is what you do. Whatever companies you are using, that's what we're going to do. Between now and lunch, I'm going to talk to you about transition. Will you install products well before October 1st? You got to ask your vendor, when is this upgrade coming? You don't want to wait till October 1st. Medicare is doing testing system. They just had one, actually last week. Medicare did. You had to apply for it. They were sold out. The next one is the beginning of June, where you can test your ICD-10 system. Some of you don't even have codes in your computer yet. Will support for my current products be discontinued, or do we have to rebuy it with the ICD-10? Okay, when will you update my current products here? Will you provide periodic updates? Will I need new hardware to accommodate ICD-10? I don't know what H&S is going to do. I'm not on their board, okay? But I'm sure that they are going to be there to help you out, number one. Number two, videos, webinars, whatever it might be. But you have to be there and be ready to help so that they can help you as well, okay? Will you offer product support? How do I report issues, and how quickly will you respond? Will you provide training on your software? Will you offer support? This video here, they're doing this here to offer support so that you can train and retrain you and your staff as well, okay? Are your EHR products ICD-10 ready? If not, when will they be? All right. My product, my vendor that I use, which I won't, it doesn't matter the brand, but they already, I called them up. I asked these questions to them. They said, we're coming out April and May are all of our transitions. So they're ready.
Mario, if I may interrupt just a minute.
Yes.
One of our staff members just said that I think this page is not in your packet.
Okay.
So, but it is in the packet. It's, first of all, it's on the H&S website under the ICD-10 section, but it's also included in the action plan we're going to give you at lunch.
Okay. Now,
I just knew a lot of people were.
I added this in because it just came out after I sent the notes in, but in addition, okay, you'll get that during lunch, okay? It's on the website, and I gave you, this is exactly where it came from. cms.gov/ICD-10. Now, I'll make an admission here, okay? This is cms.gov, ICD-10, okay? From what I saw, and we added in, H&S goes further than that. They can teach CMS, and I mean that sincerely, okay? So what you will get from H&S will take you beyond this, okay? It's going to help you out, and I mean that sincerely, okay? But I copied and pasted this because I didn't have permission from H&S to put their stuff on, and I didn't want to do that, but this is CMS's here, okay? All right, okay. So plan early. Time to contact your vendors is now. Train in stages, little bites. The statistics are, it shows that whatever I teach you today, you will remember 10%. So you remember my left eye and nothing else in my body, okay? Okay? So the key is you got to retrain your staff and retrain when possible, all right? Now it's time to change. Now is time to change. And by the way, now is time to change. We have about 6 months left. 6 months left. The delay is over. Is it going to be delayed? Okay? It's not going to be delayed. I have another class I'm teaching. I'm teaching many, but I have another class I'm teaching April 9th. All right? Everyone is saying, I don't know if I should take the class here because it might get delayed. So I'm sure April 7th, I'll have 50 people registering for the class because it's not going to be delayed. All right? So the key is do not procrastinate. Procrastination is going to be a problem. All right? Okay, Mario, you convinced me. What do I need to do? Okay? So I don't care how you write it down. You have the slides in front of you. It's not going to help you if you just sit there, okay? This is your time. I want to help you out. It's your payment. It's reimbursement. So these are the steps. This is what you need to do, okay? This is not the only way, but this is the best way I have found, and this is what I did in my office, okay? So number one, you want to identify where you currently are using ICD-9, okay? And so when you look at this, and this is what I did in my office, I did a virtual tour, okay? So you walk in the front door and in the reception room, and so now the patient checks in. Okay, so front desk, what software do you use at the front desk? This is nowhere in your notes here. This is, you got to write something down. Pardon me? Okay, she said it's in her action plan, okay? But this is a Mario thing too, and I don't know what I gave them, but I'm just telling you from Mario, and then H&S is going to hit it again, okay? But number one is what software do you use at the front desk, okay? So now it's like, okay, and I would personally, I'm just telling you here, write it down, this is the company we use, and so now that software, let's check with that vendor, make sure we're ready, okay? Now, going through the office, we go now to the boss's office, which is my wife's office. And my wife does the insurance in our office, which I like because if she embezzles, I still get the money, okay? Works, okay? All right. So what do we use for billing software? How is H&S going to help us? Are they going to be ready? Yes, they're going to be ready, okay? All right, so now the doctors, the EHR system. The codes the doctors have, they've got their own. Doctors are the worst, right? And we're all doctors, and I'm one too. We are the worst because, you know what? Hey, don't tell me I went to school and I've got hemorrhoids from sitting in class. I know what I'm doing, right? All right? And, it's kind of like, you got to change, doc. You got to help me out here, okay? And so now what the doctors need to do, and staff, you guys here, what you want to do is gather your last, I call it 40 new patient charts. This is kind of an action step, if you will, Mario style. I'm sure H&S will give you some stuff too. Okay, so now, look to see all of the new patients, and just go through the new patients that came in so far in March and all of February. What diagnosis did you assign to those patients? Make a list. That's February. January. Do the same thing. December, do the same thing. Make a list. You will find that pretty soon your codes are repeating because you have, I call it your own playlist, okay? And so now, this is my iPod, if you will, Mario's Top 40 ICD-10, okay? Casey Kasem, okay? All right, so top 40 playlists, and then literally get a book. And my book makes it nice and easy. You don't have to buy my book, but you know what? I'm a practitioner, and I'm teaching practitioners, and I make it nice and easy. So here's your code list. These are your codes. Now you look it up, and H&S has stuff on their website as well. Mine just goes through with Medicare codes as well as everything else. Okay? So it's however you want to do it. Some doctors like to have a book in front of them, others. But if it's 724.3, sciatica, you look up 724.3, ICD-9, here are the codes, ICD-10. And you convert them over. That's your playlist. You probably use about 30 codes, and now when you convert it over, it'll probably be about 50 to 60. All right? Now, are you confined to those codes? The answer is no. Expand your mind. But the key is, it's at least going to get you going so that, you hit a little speed bump, but you go, what was that? It was probably some other body, right? But you just keep going. And so now you can at least file claims while everybody else is saying, I better watch that video. And it's October 5th already, okay? All right. So you have the books there, this one here. Now, why would you use this book? If you are a multidisciplinary practice, you may want to use this book. If you do a lot of sports medicine stuff, you may want to use this book. Okay, ChiroCode book cuts it down a little bit more. If you do functional medicine, the big book is probably better, but this book here is well as well. And if you do more traditional chiropractic, that's what this and H&S's website will help you out with, okay? All right, okay. So, any questions so far? That's your transition, all right? And so now, if you did that as kind of a workshop, but we can't do it because you have to be in your office to do it, now you're going to come up with the codes, okay? You have your listing, all right? Now we have to be more specific because your codes may not be the most accurate codes, number one, and number two, your systems, the way you do things, may not be proper in the first place, and this is a time for change. This is a time for renewal. All right? And so now let's go through some of the guidelines here. We're just going to, make it nice and easy on the guidelines to help you out here. And then after lunch, once we have lunch there, then we'll go through the specific chapters that apply to your office and to my office. Okay? And I'll make it so that we drive it home. That's what we're going to do together. Okay? All right. So number one, ICD-10 codes should be listed at their highest level of specificity. All right, now, if you see the way I teach here, it's like, okay, this is it here, but what does it mean in reality, Mario? Okay, number one, we're not going to use a 3-digit code. The 3-digit code is the family name. Okay, now, fusionary, there's a lot of fusionaries out there, but, not that many compared to Smith. Okay? But if I just say it's a lumbar disorder, you'll go, what is that? Doesn't tell me anything. That's the 3-digit code. It's just the family, if you will, whether it be lumbar, cervical, or it might be arthritic codes, whatever it might be. And what it's saying is you don't use a 3-digit code if there's a 4-digit available. And this is even with ICD-9. And you don't use a 4-digit if there's a 5-digit. As an example, 722 under ICD-9 are lumbar disc disorders. If you use, I can guarantee you, if you just put 722 down as a code, it will be denied. It's not specific enough. 354 is mononeuritis of the upper limb, but 354.0 is carpal tunnel syndrome. Now, let's take it one step further here, folks, okay? This is now guidelines Mario style. You want to be as specific as you can. And the way I put it, and this is not in your notes, but you can write it down, is always ask yourself why. When you assign a diagnosis, ask yourself why. The patient has lumbalgia, which is back pain. Why? If you can answer that, then you don't have the most specific code. Think about it here, lumbalgia. Lumbalgia is, all I know is they have back pain, and I don't know why. I'm getting some special tests done, MRI, whatever it might be. All right? So, cervicalgia. Now, that's my next door neighbor, pain in the neck. Okay? All right? And so we moved, and then my wife just told me that yesterday she saw that they're moving. I am really sad. The house next door to us is up for sale, and I am hoping that they don't move there, okay? Because then cervicalgia is just going to follow me. But that's pain in the neck, and I don't get reimbursement checks for that person either, okay? So the key is, why do they have cervicalgia? Lumbalgia, cervicalgia are not good codes. Even Medicare says they're considered short-term Category 1 codes under Medicare. Palmetto has that on their website. So now investigate, examine the patient. Why do they have back pain? They have sciatica. Well, then sciatica is a better code. Even a lumbar sprain is better than lumbalgia. And the worst of them all, 728.85. Are you serious? You know what 728.85 is? Muscle spasms. Did you ever examine, x-ray the patient, sit down and do a report of findings? I have been in practice for 29 years. I have studied you inside and out, and you have muscle spasms. Ooh. Come on. That's not the diagnosis. Just take it out of your list. It's not in your playlist anymore. Muscle spasms. Yes, sir.